For this research project, I wanted to examine how genetics, unconscious bias in healthcare, and cultural stigmas contribute to racial disparities surrounding Alzheimer's disease and related dementias. Alzheimer's disease and related dementias, also referred to in short as ADRD, is a group of neurodegenerative diseases that result in cognitive impairment and, in the case of Alzheimer's, a progressive decline in memory and autonomy. ADRD typically affects individuals aged 65 or older. Recent research estimates the prevalence of ADRD to double or triple by the year 2050. Statistical analysis projects Hispanic populations to see the largest increase in ADRD up till the year 2060, followed by the Black population with the second largest increase, as you can see in the graph. Currently, 14.7% of Black people older than 65 are diagnosed with ADRD, followed by 12.9% of older adult Hispanics and 11.3% of older adult non-Hispanic whites. Research findings on the role of genetics concluded that genetics may not play that significant of a role, evidenced by the fact that no significant differences in beta amyloid concentration or tau levels were found between Black and white participants not carrying the APOE4 gene. Also, Black and white participants diagnosed with clinical dementia shared similar biosignatures when tested after onset of symptoms. In regard to unconscious bias, low to moderate levels of implicit bias towards Black and Hispanic populations were found, and patients perceiving racism were almost 4 times as likely to delay or forego care. Individuals delaying or foregoing care may discontinue services from healthcare, not fill prescriptions, or wait too long to seek medical advice, all of which can worsen health outcomes. Biomarker research is crucial in this case because it can serve as an unbiased measurement of Alzheimer's onset symptoms. In regard to stigmas surrounding ADRD, half of participants in a general population study expected someone with Alzheimer's to be discriminated by employers or to have limited insurance. This indicates possible apprehensiveness in seeking medical attention if symptoms of ADRD were to appear in themselves or a loved one. So Latino and Chinese caregivers were less likely to think of as effective compared to white participants. Also, Black, Latino, and Chinese caregivers were more likely to think Alzheimer's symptoms were a normal part of aging compared to white caregivers. This belief that Alzheimer's symptoms are a normal part of aging is a large reason for why many cases are not diagnosed in time for medical intervention to be effective, because Alzheimer's symptoms are abnormal parts of aging. Also, Black participants were more likely to appraise God's will as a risk factor for Alzheimer's. It is important to recognize that cultural stigmas will not be the same across minority ethno-racial groups. Understanding the values, traditions, and concerns in these groups will be beneficial in creating educational outreach programs tailored to specific communities. Chinese caregivers expressed fears of rejection by others in the community for living with someone with ADRD. Chinese communities reportedly may hold beliefs of ADRD as being contagious and indicative of bad feng shui, often leading to caregiver families being socially outcasted from people who were once their friends. Latino caregivers brought up cultural traditions of taking care of a loved one until they pass away, or the idea that La Familia stayed in the household till death. Most expressed the belief that it was disrespectful or that was the easy American white way to opt to send a loved one with Alzheimer's to an assisted living facility. Also, Latino families were notably motivated to learn about Alzheimer's, particularly after learning that memory loss is not a normal part of aging. African American participants were significantly vocal about experiencing disrespect, dismissiveness, and misdiagnoses from physicians when reporting ADRD symptoms. African American participants in multiple studies reported feeling more comfortable seeking advice from religious figures in their community as opposed to a physician. This generally negative attitude toward healthcare systems may contribute to racial disparities. Keep in mind that these cultural stigmas are not representative of one race or ethnicity. They mainly reflect the communities from a specific population sample from the study. However, these findings do demonstrate how stigmas can vary between racial and ethnic groups. In this case, what could be done to navigate the different cultural climates? So to answer that question, in Chinese communities, outreach programs could address all community members rather than solely caregivers. This would combat the negative stigmas surrounding those living with Alzheimer's in the community and increase social support. For Latino communities, instead of encouraging assisted living facilities, it would be more beneficial to reach out to caregivers with training programs. This would respect the sentiments of keeping family members with ADRD in the household, and many families would readily arm themselves with knowledge they need to better care for their family member that has an ADRD. For African American communities, a high level of religiosity indicates that educational outreach programs should try to coexist with these religious coping strategies, which have been shown to increase optimism and positive outlook. It should also be emphasized that ADRD symptoms are not a normal part of aging in these populations. Sensitivity training for physicians is another step that could be taken to combat negative attitudes held towards aspects of healthcare. That concludes my discussion of the recent literature on the topic of racial disparities surrounding Alzheimer's disease and related dementias. Thank you for listening.